Okay, now for urinary elimination part 2. Let's talk about what causes alterations in urinary elimination. So first of all, cystitis is something that can alter urinary elimination, and cystitis occurs when there's bacteria that travels up the urethra into the bladder and it causes a bladder infection. So if that's not treated quickly, then the infection can progress upward to the ureters or to the kidneys, and so a kidney infection is called pyelonephritis. Urinary retention is also something that can cause urinary elimination, and urinary retention is an ability to empty the bladder completely. So some things that cause that are obstruction, inflammation, swelling, neurological problems, medications, anesthesia, anxiety. There's several things that can cause urinary retention. Urinary incontinence is a lack of voluntary control over urination, and that will affect about 2/3 of older adults, at least to some degree, and it is very much associated, incontinence, with skin impairment. So urine is so irritating to the skin. So incontinence is associated with skin impairment, also associated with obesity, UTIs, self-rated poor health, reduced mobility, depression, and increased caregiver burden. It very much can lead to social isolation and, like I said, increased caregiver burden. So a urinary diversion or a urostomy is something that's surgically created, and it's a surgical opening that's created for the elimination of urine. And urostomies are used to treat patients that have any kind of condition like cancer, trauma, maybe some type of birth defect, or some kind of disease of the urinary system. So a patient with a urinary diversion cannot eliminate urine normally via the urethra. So instead, the urine bypasses the bladder and it's expelled through a stoma or an ostomy. So UTIs happen when microorganisms that normally live in the colon, live harmlessly in the colon, when they enter the urethra, and then they begin to multiply, and then it overwhelms the normal flora. So E. coli is something that commonly causes UTIs. And remember, the classic signs of UTIs are white blood cells in the urine, pain with urination, and having the urge and frequency. So like when you feel like all of a sudden, oh, I have to go immediately and I could barely make it to the bathroom on time, that's urgency. And the frequency, you're just going a lot more than what you normally do. So those are classic signs of a UTI. How do we manage urinary retention? So again, urinary retention is the failure of the bladder to empty completely. So we want to measure PVR, and that means post-void residual. So that is going to measure the amount of urine that's left in the bladder. So a small amount is normal, you know, of 15 to 20 cc's or whatever is normal. But if there's like 200 mils of urine left in the bladder after someone voids, that's a problem. A bladder scan is what we can use to measure PVR. So you get lube gel over the abdomen, you use an ultrasound probe just right over the bladder, and we can measure and we can see how much urine is in there. Then if we see, you know, there is indeed urinary retention, we can use a straight catheter. So that's a way to manage urinary retention. So a straight catheter, like we've done in the lab, that single lumen tube, and that's inserted, and it's just inserted for the immediate drainage of the bladder. And then after that bladder is empty, or after you get your urine specimen, you remove the catheter and you throw it away. And then the patient will go back to urinating just on their own. So an indwelling catheter, also known as a Foley or retention catheter, that is used for continuous bladder drainage. Usually it's a double lumen, so that we have the one lumen that's used for urine drainage, and then the second one that's used to inflate a balloon near the tip of the catheter, and then we can have a triple lumen indwelling catheter, and that's when the patient requires intermittent or continuous bladder irrigation. And then the last is suprapubic catheter, and that is used for continuous urine drainage and that is more long-term even than an indwelling catheter, and that's when the urethra has to be bypassed. So because of some gynecological surgery, or if there's prostatic obstruction or some other kind of trauma, a suprapubic catheter is inserted through an incision. The incision is right above the symphysis pubis, and then that catheter is sutured right in place, and then a bag is placed to drain urine. So urinary retention can be acute and it can be chronic. Especially for patients with chronic urinary retention, then the nurse can give education about how to manage the symptoms at home. So one thing they'll teach is called Creday's maneuver, and what that means is you'll put pressure with your hands right under the navel and over the bladder, and that helps put force on the bladder to help with bladder emptying. There's a picture on the slide. Also, the nurse can provide education to the patients, especially women, on how to perform Kegel exercises. And doing Kegel exercises will improve tone, and it can also increase the control and flow of urine. Also wants to teach patients that here are some risk signs. So you need to call your healthcare provider if you are experiencing any of these symptoms. Completely unable to urinate. If you have intense pain in the lower abdomen, in the urinary tract, if you have fever, vomiting, back pain, chills, if you're passing a real small amount of urine for like 1 to 2 days, or if you have any blood in the urine, if your urine is cloudy or foul smelling, and if you have a lot of frequency and urgency, all of those things are red flags, and you need to talk to your healthcare provider about that. So how do we manage urinary incontinence? So what we want to think about is preventing skin breakdown, because normal urine is acidic. So when it's in contact with the skin, it becomes alkaline, and it's going to cause dermatitis, it's going to cause excoriation to the skin. So we've got to keep the skin and the clothing and the bedding and everything dry. Barrier creams sometimes can be used if the skin is irritated. Sometimes antifungals might be prescribed, like nystatin or mycostatin, and that's going to eliminate fungal growth, or it can prevent fungal growth. You can also use absorbent products to help with control measures. Lifestyle modifications. So those can be things like dietary changes, increased fluid intake, avoiding caffeine, trying to prevent constipation, things like that to help improve quality of life. And fluid restriction is just recommended only if daily fluid intake is more than 3,000 mils. Bladder training. So the goal of bladder training is to help the patient be able to hold bigger and bigger volumes of urine in the bladder, and to increase the interval between those voidings. So this is going to involve some teaching, scheduled voiding, and then also self-monitoring. And then Kegel exercises. So Kegel exercises are the most commonly used method for preventing incontinence and for reversing incontinence in women who have incontinence after giving birth. So this is something that can help older women and older men that are going through prostate surgery. So that can help reduce urinary incontinence. So the cure rates of urinary incontinence are about from 16 to 27%, and improvement rates vary from about 48 to 80%. So medical interventions, pharmacological interventions. So estrogen sometimes is prescribed for postmenopausal women that are incontinent, especially if that incontinence is secondary to atrophy in the vagina. So for urge incontinence, medication might be used to relax that detrusor muscle, and then also to increase bladder capacity. And some medications for that are anticholinergics, smooth muscle relaxants, antidepressants, calcium channel blockers. All those things can help relax the muscle and increase bladder capacity. So for stress incontinence, drugs can be given to improve that sphincter muscle functioning. And what stress incontinence is like if somebody sneezes and urinates a little bit, or they cough and urinate a little bit, that's stress incontinence. Surgical interventions. So surgical interventions can be appropriate if incontinence is caused by a cystocele or a rectocele or an enlarged prostate gland. So in those cases, surgical techniques can be appropriate. And there's a picture on the slide of a cystocele. And a cystocele is when the wall between the bladder and the vagina weakens. And so that means that the bladder can drop, it can sag into the vagina, and it can be caused by anything that can increase pressure on the pelvic muscles. So urinary diversions. There are different types of urinary diversions, and a urostomy is like a basic urinary diversion, and that's through surgery when there's an opening created for urinary elimination. So a patient that has a urinary diversion doesn't eliminate urine through the urethra, but instead the urine bypasses the bladder and then it's expelled through a stoma or an ostomy. So the patient doesn't have voluntary control anymore of urination. The urine just constantly flows through the stoma and it's collected in a little pouch that the patient wears. So most of the time, people that have urostomies are people that have some kind of urinary system defect or trauma. Some risks associated with urinary diversions are, of course, infection, permanent kidney damage, and that kind of permanent kidney damage can occur from hydronephrosis. And hydronephrosis means distension of the kidneys with urine, and that results from obstruction of the ureter. So interventions for patients with urinary diversions. Initially, you want to assist the patient with care of their urostomy, help them understand the function, how they take care of it, how do they change the bag. And the long-term goal, of course, is for the patient to become comfortable with their own body and to assume self-care over that. So here's a picture of a cutaneous ureterostomy. And so this is a surgery that reroutes the ureter. And so the ureter comes directly to the surface of the abdomen and it makes a small little stoma. So this procedure isn't routinely used. It has a little bit limited use, and that's just because there's a pathway of pathogens for the skin to enter the kidney. So that's kind of a risk for that. The stomas are pretty small and they're also difficult to fit with a bag. Here is the one that's more commonly used, and that is conventional urostomy. You'll also hear these referred to as an ileal conduit or ileal loop, Bricker's loop. You'll also hear that. This is the most common type, and the reason it's the most common is because it's the simplest to perform. It's a simple surgery. It eliminates the need for the intermittent catheterization. So the ureters are implanted into a loop of the ileum, and remember the ileum is that last segment of the small intestine, and so then the urine drains freely from there into the stoma bag. And then next we have a continent urinary reservoir. So you'll hear this called an ileal reservoir. Sometimes you'll hear it called an Indiana pouch, and that's similar to the ileal conduit, but urine drains into a pouch that's actually made from a portion of the large intestine. So the stoma on the abdomen contains like a valve to keep the urine from leaking. And the patient inserts a catheter into the stoma, and that catheter drains urine through the valve. And then there's a neobladder. Neobladder just means new bladder, and that mimics the function of a urinary bladder. So a portion of the intestine is made into a pouch, and this reservoir is like connected to the urethra. And so just like normal passage of urine, urine passes through the urethra, and the patient voids by bearing down or applying manual pressure over their new bladder using that Credet's maneuver to empty the bladder. They may also need to occasionally use self-catheterization, but for the most part this will help them empty the bladder. So this kind of urinary reservoir doesn't require any kind of external stoma or bag, and it's common to have a little bit of urinary incontinence after this surgery, but it usually resolves within a few months. Okay, so here's a question I want to leave you with. So you're caring for a frail, elderly woman, and she has overflow incontinence. So what physical and emotional issues would you expect her to experience? Come to class ready to talk about overflow incontinence and to talk about physical and emotional issues that would be normal in this scenario. Okay, bye.